Today, I have the pleasure of talking to Dr. Charles Cleland.
I'm an ophthalmologist and clinical research fellow. Most of my work has been in Tanzania.
We're going to talk about health inequity in eye care.
A lack of specialists, limited funding for healthcare. In the absence of screening, people often present late with very advanced disease. They go irreversibly blind as a result. AI can help with this challenge.
AI bias sort of ties into health equity.
There's definitely a lot of concerns about this. AI devices that predominantly trained on European
white people.
The population of the world is going to shift a lot over the course of this century. 1 in 10 people born in the world will be born in Nigeria. There's relatively little work done on applying AI devices to Black African populations. It's very expensive, basically. So I think it's still a little bit of an unknown. Unless we use technology to help with that, we could well see very large increases in the number of people who lose vision.
Today, I have the pleasure of talking to Dr. Charles Cleland, ophthalmologist and clinical research fellow based at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine. We're going to talk about health inequity, particularly for eye care, why it's such a problem and how AI can help us address it. Thank you so much, Charles, for joining me today at Future Medicine AI. Could you give me a bit about your background and where you are today?
Yeah, sure. Thanks for the invitation to come today. So I'm Charles Cleland. I'm an ophthalmologist and clinical research fellow, currently working at Moorfields Eye Hospital and the London School of Hygiene and Tropical Medicine.
Awesome. And you've done a lot of work on health equity, haven't you? So that's, I think, your specific research focus?
Yeah, so my specific area of research is on the application of emerging technologies, including artificial intelligence, to try and improve eye health in low and middle income countries primarily. And most of my research has focused on diabetic retinopathy.
Right.
And most of my work has been in Tanzania, where I was based for about 2.5 years up until the beginning of 2025.
Awesome. Touching on health inequity and sort of the barriers for under-resourced areas to access routine eye screening, what are the main barriers for these regions to access like routine eye screening?
So I think access to healthcare generally, there's a lot of inequity in that. And eye care, as you say, is certainly no exception. And there's data that was presented in the Lancet Commission on Global Eye Health, which is a good report. If anyone would like to read a bit more about this, that reported in 2021. And in that, and also in data from the Vision Loss and Expert Group, it's estimated that there are around 1 billion people in the world who have some degree of vision impairment.
Wow.
And the vast majority of those people live in low and middle income countries.
Wow.
And the other crucial thing is that most of the conditions, sort of 90% of the people who either have vision impairment or blindness, are visually impaired or blind from a condition that's either treatable or preventable. So the main causes of vision impairment and blindness today remain refractive error and cataract. Refractive error is treated with glasses. That's an invention that's 5,000 years old, but a lot of people just don't have access to a good quality pair of glasses and are visually impaired or sometimes blind as a result of that. And then cataract, which, as many people know, is treatable with a simple operation that takes 15 minutes to do. And is in fact the most common performed operation or one of the most common performed operations in the UK, and has very good outcomes. But again, in many parts of the world, particularly in lower resourced parts of the world, access to these two things is often limited, and people therefore live with avoidable vision impairment and blindness as a result.
Wow, it's quite stark, that figure, 1 billion people with about 8 billion population in the whole world. I think the health equity gap for eye conditions is not very well covered by the media, particularly like when we think about other concerns in AI, like data leakage or more exciting use cases like, this AI system has just detected this disease with this level of accuracy. Why do you think that is?
So I think one of the reasons for that is probably related to the fact that a lot of the groups within countries and globally that are less that are affected by that are marginalised groups that receive less media attention generally. So, for example, if we take the devastating civil war in Sudan that's ongoing at the moment and has been since 2023, that has received a lot less media attention than, for example, the war in Ukraine. And I think that is kind of exemplified in a less of a focus on health inequity globally when it comes to AI. So I think it's a sort of representation of the fact that those bits of the world, or often those groups within society that are more affected by these sort of issues, are just receive less media attention.
Right. With regards to diabetic retinopathy, which I think you've had a heavy focus on in your research, is that correct?
Yeah, that's right. Yeah.
So could you explain a little bit about why diabetic retinopathy is so dangerous? Why your main focus is on improving screening for retinopathy in particular, and why there's a general increase in AI's use cases for diabetic retinopathy in comparison to other conditions?
Yeah, sure. So diabetic retinopathy is a complication of diabetes. So diabetes is a condition where your body doesn't manage blood sugar very well, and it can cause damage to blood vessels in different parts of the body, one of which is the retina. And what can ultimately happen is you can get complications from that related to new vessel formation or leakage of fluid, which can ultimately result in irreversible blindness. Diabetic retinopathy, we know, has very good effective treatments that have been available and around for many decades. And we know that if people receive those treatments promptly, up to about 95% of vision impairment and blindness from diabetic retinopathy can be prevented. One of the problems with the condition is that until you have quite severe diabetic eye disease, you often might have no symptoms. So in the absence of screening in many low-resourced countries, for example, people often present late with very advanced disease, which is much less responsive to treatment, and as a consequence, they go irreversibly blind as a result. In countries like the UK, we have a very good national screening program that has been running for over 20 years now, I think. The point of that is basically to detect people who have early changes from diabetic retinopathy and connect them to eye care services where they can be assessed and treated promptly. And in the UK, for example, diabetic retinopathy did used to be the leading cause of blindness in people of working age. But since the introduction of the diabetic eye screening program in the UK, it's actually now no longer the leading cause of blindness in people of working age. So, that would suggest and indicate quite strongly that it's an effective way to reduce vision impairment and blindness from diabetic eye disease in this group.
And your work on diabetic retinopathy in Tanzania, what were you doing there?
So, as I mentioned, in lower resource settings for different reasons, one being a lack of specialists, two being limited funding for healthcare, particularly limited funding for eye care, means that there's often not very strong screening and treatment services available for diabetic eye disease in countries like Tanzania, in many African and Asian countries as well. So there are sort of some screening programs for diabetic retinopathy in different African countries, and where I was based in Tanzania at the Kilimanjaro Christian Medical Center in northern Tanzania, there is actually a screening program that has run since 2010. But that, as with many other programs in other low resource countries, struggled because of the reasons I mentioned before. It doesn't have enough specialist staff to really get clinicians to focus on grading retinal photographs for diabetic retinopathy, and there are some issues around sort of sustainable funding of the program as well. So with those kind of issues in mind, we recognized there was a potential role for automated AI-based technologies to help with that. So these AI technologies work by automating the interpretation of retinal photographs for the level of diabetic retinopathy, which means you don't need trained specialists to look at eye photographs and decide who needs referral to a hospital or not. And you don't have to pay people to do that grading, or you may have to pay for the AI device, but there's a potential cost saving there as well. The other advantage of it is that you're able to give people the result there and then at the point of screening. So in the program in Tanzania where I was based, generally that had people had their photograph taken and then they had got their result 2 or 3 weeks later by telephone or text message. And we found that a lot of people were screened and referred to the eye clinic, but actually only about 40% of people were making it through to the eye clinic. So lots of people were being identified with a level of diabetic eye disease that needed at least assessment and potentially treatment, but actually less than half of those people were making it through to the clinic. So what we thought was, well, one, AI can help with the human resources challenge in regards there being a lack of specialists to run these programs, and two, it can provide a point of screening diagnosis to enable patients to be given their result before they leave the screening room, and that might help along with face-to-face counselling, that might help increase the number of people who are referred who actually attend the clinic. And just to give a bit more context, in Tanzania there's not a sort of healthcare infrastructure where people can be sent letters like they might be in the UK. That doesn't really exist. So it's quite difficult for patients with chronic diseases to sort of remember and get appointments scheduled in the way that they are in the UK. So I think those kind of point of care results potentially have a role to play in strengthening follow-up of patients in countries like Tanzania. So we basically ran a randomized controlled trial in Tanzania where we tested the standard screening pathway to the AI screening pathway, and we looked at the outcomes between the two in terms of, okay, here's an AI device that hasn't been trained on an African population, but when we actually implement it in an African country, how well does it work in terms of detecting people who have sight-threatening diabetic eye disease? And through a point of care diagnosis, does it help connect more of those people who are living in the community with severe diabetic eye disease to the eye clinic where they can be assessed and treated?
Do you think that the considerations for AI in this particular case, it's different for Tanzania, for example, as opposed to over here? I'm thinking that, for example, AI over here, there's a lot of risk of a high number of false positive cases and then overwhelming NHS urgent referral pathways. And because ophthalmologists are obviously very stretched over here, that's a risk that people are quite concerned about. Whereas in Tanzania, maybe because there are fewer ophthalmologists available, I think, maybe that's less of a risk, and actually you want more false positive cases from an AI system to flag any potential risks.
So yeah, I mean, there's certainly many fewer ophthalmologists in Tanzania compared to the UK. So the figures are that in high-income countries, there are about 71 ophthalmologists per million population. In low-resource countries, there are about 2.5 per million population. So there's substantially less ophthalmologists in countries like Tanzania. I think the issue of false positives is potentially more of an issue in a country like Tanzania. So where you have very limited specialists in hospitals who are already having a high workload because there's relatively few of them per million population. If we start burdening those clinics with lots of false positives, i.e. people who've been referred from a screening program who don't really need to be in the clinic, that's going to be probably more challenging even in a country like Tanzania. And I think that's one thing we need to be cognizant about when thinking about implementing these technologies, these diagnostic technologies, is that we don't want to overwhelm health systems that are already kind of struggling to cope. So I think both in the UK and in Tanzania, that's certainly a challenge. I mean, I think a difference between the two, as I see it, in somewhere like the UK, I think AI technologies primarily will have a role in terms of being more cost effective. And that's how they're going to contribute to sort of improving the system as a whole. I think in somewhere like Tanzania, or other African countries or Asian countries, I think there's more of a potential role for them to actually improve patient outcomes.
Okay.
Because a lot of people in, say, Tanzania just don't have access to eye care. And that's as for the reasons we've already mentioned. And so if you can then, potentially quite rapidly give very large numbers of people access to really good diagnostics, that could really impact outcomes in terms of reducing blindness, vision impairment. In somewhere like the UK, people with diabetes already have access to a very good eye screening system. So implementing AI into that isn't really going to change how many people go blind as a result of diabetic eye disease. But what it might do, and there's evidence to suggest this, is save quite a lot of money. So some analyses have suggested it would save the UK diabetic eye screening program about £10 million a year, which is quite a substantial, saving. And I think that's the same in radiology, for example. There will be some cases of this, but generally people are not dying because nobody got round to looking at a scan or an X-ray. But if you can start automating interpretation of X-rays and CT scans, you can probably make hospitals more cost effective and, therefore save the whole system money.
Do you think that there's also a place for AI to help with treatment options? Because obviously it's one thing improving the number of people that are diagnosed or increasing the number of patients identified. It's another thing actually being able to treat those patients. So how do you think those two aspects of healthcare can be matched?
Yeah, well, I think that's a very important point, because ultimately you can have these really fancy sounding AI systems that help with diagnosing this, that, and the next thing, and they don't need, human involvement, or at least, relatively limited human oversight. But ultimately, that doesn't prevent someone who's got really bad diabetic eye disease going blind. You still need a doctor to treat them for, with laser treatment or injections or whatever it is that they need. So I think that it's very important that we remember that, and that, in any country, good screening services has to be coupled with good treatment services that are affordable and effective. And without that, the best AI screening tool is not going to make any difference. I think in ophthalmology, most of the focus in terms of AI is on diagnostics. So it's helping detect people who are at risk of sight loss from, whatever the condition of interest is. I think in ophthalmology, there's less of a role in terms of guiding, in terms of changing the way treatment is delivered. Ultimately, you're still going to need someone to operate on the cataract or deliver the retinal laser. But I think in other areas of medicine, there are potential applications of AI to, for example, identify novel targets for drugs, or new chemotherapeutic agents, for example. So I think in other areas of medicine, yes, but for eyes, it's mostly diagnostics.
Awesome. Going back to Tanzania, so your work with automation and eye screening, is this now kind of proof of concept? Is the AI that you've been working on, is that up and running in the establishment where you were working in? If not, if it was just research, primarily research focused, what barriers do you think still need to be overcome to actually get AI into more healthcare establishments in these under-resourced areas? So with that project, the trial that we did, which completed about 6 months ago, we were doing that in partnership with the Ministry of Health in Tanzania. And now on the back of that work, we're kind of translating this from the research phase, which is what that
project was, where I was based in Tanzania, and are now trying to translate that into clinical practice in different regions of Tanzania. And we're continuing to do that work with the Ministry of Health. So we've got an ongoing project that's running at the moment where we're integrating AI diagnostics into 4 different regions of Tanzania into the screening programs that already exist in those areas. Our colleagues at the Ministry of Health in Tanzania recognize and are sort of hoping to capitalize on the advantages of AI diagnostics for improving diabetic eye screening in Tanzania. And I think it's just, I didn't mention this earlier, but the number of people living with diabetes is projected to rise globally, but the biggest percentage increase in the number of people with diabetes is in Africa.
Right, wow.
And actually Tanzania is one of the countries that has a pretty high prevalence of diabetes, and that's projected to rise very substantially over the next kind of 20 years. So there's already a shortage of eye care specialists. And I think people working in Tanzania recognize that it's not going to be possible to train a future generation of ophthalmologists to kind of deal with this growing burden of demand for diabetic eye care services. So unless, we use technology to help with that, we could well see very large increases in the number of people who lose vision from diabetic eye disease. But hopefully by sort of capitalizing on these automated technologies, that can help with that growing demand and the already low number of ophthalmologists that are in Tanzania. So we're doing that in Tanzania, and then colleagues of mine at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine coordinate something called the Diabetic Retinopathy Network, which is a group of eye hospitals in low and middle income countries that are partnered with hospitals in the UK, and they are working to improve their diabetic screening and treatment services. And so there are over 20 of these partnerships, or well over 20 of these partnerships in about 20 plus countries in Africa, Asia and Latin America that are sort of working to improve these services. And ultimately, we hope that Tanzania can become a kind of exemplar for some of these other countries to start learning about how they can adopt AI technologies into their programs as well. Because, of course, all these places suffer from the same issues as Tanzania in regards lack of specialists, difficulty giving people follow-up appointments, high rates of loss to follow-up in screening, late presentations, etc. So, hopefully over the next 10 years or so, we can kind of use Tanzania, as I say, as an exemplar, and then sort of roll this out to support other countries in diabetic eye services as well.
It's a really good point you make about more ophthalmologists not being enough, because this is an argument that is consistently brought up across all areas of medicine, particularly dermatology, as well. It's like, we just need more dermatologists. We just train more dermatologists. And actually that won't work, and that won't solve the crisis because of increasing numbers of people expected to develop the disease.
Yes.
What do you think is driving the projected increase in number of diabetes?
Yeah, so if we take Africa, which is, as I say, projected to see the largest percentage increase in the number of people with diabetes, there's a couple of things that are driving that. One, demographics. So the population of sub-Saharan Africa today is around 1.2 billion. By the end of this century, it's projected to be 4 billion. And I read a statistic somewhere that I think in 2100, 1 in 10 people born in the world will be born in Nigeria, for example. So the population of the world is going to shift a lot over the course of this century, and Africa is going to become a very large percentage of the global population. So as a result of that, simply there are going to be lots more diabetic people because it's a much higher proportion of the global population. So I think that's one reason. Two, the people in Tanzania, for example, at the moment, about 50% of the population are under 18. those people are now adolescents. In 30 years, 40 years, they're going to be middle-aged people. So you've got a sort of population pyramid shaped like this.
Sure.
Lots of young people, not very many old people. It's going to go like this. So you're going to have lots of middle-aged people, and it's middle-aged people generally who get diabetes, etc.
Yeah.
So the population is growing and it's getting older, and the population is also urbanizing. So you've got quite a shift in the way people are living, and people are moving from rural areas to urban areas. And when people move to urban areas, they start having Western diets. They get, more sedentary lifestyle. They eat Western food and they get bigger, basically. And as a consequence of that, develop or are more likely to develop diabetes. And for example, the Dar es Salaam is the sort of commercial hub of Tanzania. It's the biggest city. Population of Dar es Salaam at the moment is about 5 million. By 2100, the population of Dar es Salaam alone is projected to be 70 million.
Wow.
And it's projected to be, I think, the third biggest city in the world. So you can just taking those figures, I mean, that's bigger than the population of the UK, for example.
Yeah.
So that just gives you a sense of just how rapidly the population is growing and how rapidly these cities are growing. And as a result of that, diseases like diabetes, heart disease, etc., are just going to get a lot more prevalent. So I think those are the main factors.
That is absolutely shocking.
Yeah.
I can't believe that. Going back to AI in Tanzania, how do you think the safety considerations differ from over here in the UK? Because obviously I think the UK is kind of renowned as quite strict in its regulation on the use of AI. Is that reflected in Tanzania, or is it very different? Is it all about innovation over there?
I think Tanzania is sort of further behind the regulation of AI sort of cycle. So I think in the UK we're much more aware of that, and there's a lot of work going into that. I think in Tanzania they have a medical regulator body, the Tanzanian Medical Devices Authority, TMDA, that regulate drugs and devices that are being used in Tanzania. And I've had some initial conversations with them about regulation of devices and things. And AI is not really a big focus of theirs at the moment.
Right.
So it's a little bit unclear exactly what the regulatory requirements for using an AI device in Tanzania would be. And I think that is kind of still maturing. I think that'll change quite quickly. But I think they're a little bit behind European countries in that regard. I think one thing, we kind of touched on this a little bit earlier, but I think one thing that will definitely be an issue and will be something that regulators in countries like Tanzania will be focused on is looking at AI devices that are developed by European, American, Asian groups that are predominantly trained on European, white or Asian populations, how well they generalize to a Black African population.
Yeah.
And so I think that'll definitely be one of the things that regulators will definitely be looking at, is this device, which was trained on a UK population, able to perform safely and adequately in a population in Tanzania.
Yeah.
And there are quite a lot of concerns about that.
Really, really good point, because AI bias sort of ties into health equity quite well. A few months ago, we found that an AI used to detect breast cancer from mammograms was performing significantly worse in Black patients and Hispanic patients than in white patients. And that's because the training data is primarily from white people. So have you seen a lot of that in ophthalmology?
Yeah, I mean, I think there's definitely a lot of concerns about this, and there's good work that's been done looking at the representation globally of ophthalmic imaging data sets for training AI models, and populations in lower resource countries are definitely underrepresented in that training data. Therefore, as a result of that, concerns about how well models trained on these populations will generalize to others. If we take African populations, there's relatively little work done on applying AI devices to Black African populations and seeing how well they work. So I think it's still a little bit of an unknown in ophthalmology, but there is some work related to glaucoma and diabetic retinopathy where people are beginning to see that these models may not work so well in different ethnic groups. And that's definitely a problem, because one of the risks with AI is that it could just sort of perpetuate existing inequities. And I can imagine a world where European American populations have access to very slick, sophisticated, personalized AI powered diagnostics, and populations in countries like Tanzania just don't have access to them, either because they're not developing their expertise to do research and implement these devices within their health systems, or because the AI devices simply don't work very well in their populations. So what I see, one of my roles and what I would like to contribute to is trying to, in the small ways I can, stop that from happening. So try and encourage researchers in Africa to get involved in this, get experience and exposure to clinical AI research in ophthalmology, and then support programs where we can to start integrating these tools into their systems to try and reduce the risk of that happening in the future.
And I think a big factor in reducing that risk is having bigger data sets with more diverse populations. The UK, I think, is doing a really good job at tackling bias, because we have Insight iHub, the biggest bio-ophthalmologic database, I think, in the world, collecting loads and loads of eye scans from Moorfields Eye Hospitals and using that data to then increase the performance of AI tools, because it's representing the UK, and the UK is quite diverse. For somewhere like Tanzania, theoretically, to get an AI system that's performing very well for these populations, you'd need a lot of data. How can they get that data?
So with difficulty. So basically, it's very expensive and time consuming to collect the data and organize it in a manner that can be used in AI research. So in the UK, our health system isn't perfect, but we have, at Moorfields, for example, there's a pretty good infrastructure set up that allows researchers to access imaging data and link that with the sort of clinical metadata to build a data set that has enabled this kind of work to be done. Now, I know that whole process, I've sort of made that sound very easy. I know a huge amount of work went into doing that, but there was sort of the background infrastructure that was there that facilitated it. In Tanzania, that doesn't really exist to nearly the same degree. So I think that's the first problem. It's not going to be possible to sort of pick up routinely collected data and then organize that into a data set that can be used. What probably needs to happen, and we are working towards this, is to set up a deliberate cohort of patients that we collect data from and follow up over a period of time to collect a bigger data set of imaging and clinical data from an African population that can then be used in this kind of research. But the problem with that is it's very expensive, basically.
Right.
So you need often to procure and buy the equipment in order to collect the imaging data, which, in somewhere like the NHS, that already exists in a lot of departments. So you need to potentially buy fundus cameras, OCT machines, etc. You then need to employ the staff to examine, collect all the data, organize it properly. And a lot of that would kind of in the UK be sort of covered through the routine clinical data that gets collected when people attend Moorfields or whatever. I think with money and with deliberate efforts being made to collect those data sets, I think it's possible. But without those two things, it'll be difficult.
And it's not just racial biases, there are other biases as well, like gender bias. Have you seen that in ophthalmology as well? So
yes, I mean, if you take, so I think it's around 55%, 55 to 60% of people who are blind globally are women. And you might say, well, that's because women live a bit longer than men. But actually, when you age standardize that, so you adjust for the age differences, you're still more likely to be blind if you're a woman.
Right.
Women have less access to cataract surgery globally, for example, as well. And in conditions such as trachoma, which is the commonest infectious cause of blindness still, although is being eradicated in many countries now, women are much more likely to be blind as a result of that. So there are globally, there are definitely issues with gender access to eye care. I don't think in the UK that's so much of an issue. I may be wrong, but I don't think so. But I think in countries like Tanzania, which is quite patriarchal, about 60, if you're a woman, you seem to be more likely to get screened. But if you're referred, you're less likely to actually connect.
Way.
Yeah. And I think that's partly because, men are out working and whatever. So when the screening's done during the day at the local hospital, they're out busy working.
Yeah, okay.
Whereas for a woman, it's relatively easy just to go to the local hospital during the day because they're not at work. But actually, when they're referred, you're less likely to comply with that advice if you're a woman. So it's sort of,
Why do you think that is?
We did do some work on this, and I mean, we found that in Tanzania, women are, the man is sort of the one who sort of controls the purse strings and sort of says yes or no. And women therefore have less sort of financial independence, basically. Whereas if it's the man and he's told to go and it's up to him, he can just sort of decide to do it. So I think that's one issue.
Wow.
And then we found, simple things as well, like a lot of the women didn't really know how to get to the referral hospital if they were from quite rural places.
Right, okay.
They weren't used to moving around. They just didn't know how to get there and they didn't know where it was.
Wow.
So, simple things like that as well.
Yeah. It's really interesting, though.
Yeah. I think it's probably because, less sort of money, less autonomy about their own health.
Yeah. And do you think there's a risk of collecting a load of training data, theoretically, if that was possible and easy to do?
Yeah.
A load of training data. But what if the training data itself contributes to and exacerbates these biases? Thinking of a 2016 study, this is not related to ophthalmology, but it's a good example of what I mean, where medical students and residents were asked to diagnose pain and prescribe treatment for pain, and inherently they found that they were less likely to prescribe effective pain treatments for Black patients because of the stigma that Black people have thicker skin and therefore feel less pain. So it's really interesting that these kind of biases could still be perpetuated even in this modern age. Do you think there's kind of a risk, particularly with women here? For example, maybe women are less likely to be taken seriously from their symptoms if in Tanzania it's a very patriarchal society. Do you think there's a risk that even if a lot of data is curated, that we still churn out these biases that then worsen health equity?
I think that is a risk. So I think the first thing is to be cognizant of that and aware of it. And once you recognize it and understand that it's a risk, you can then take steps to mitigate it. So I think one of the key things with training data for AI in general is that it needs to be representative of the population that you're looking to study. And that would be one of the advantages of deliberately collecting data from a group of people rather than routinely collecting it. You could make sure that the training data that you collect and store as a training data set is representative of your population, and that would be in terms of gender, in terms of age structure, in terms of ethnicity. And if we do take the UK for example, generally a lot of the people who enroll in research studies tend to be more affluent white people. So for whatever reason, ethnic minorities often tend to be less keen to engage with research projects in the UK. And that is one reason why they're underrepresented in some of these training data sets. So I do think there are public engagement activities that can be done to try and sort of improve that. But I think it's good to have, that we're having this conversation and discussing this, because I think the first step to being able to do something about it is, at the beginning, recognizing that it's a problem.
Yeah.
And therefore going into whatever project you're doing knowing that this is an issue, and then you can take steps to mitigate that where possible.
Yeah, absolutely. And from a global perspective, one of the risks I think about using these AI systems is that for the UK, it's very much easier to get these systems out and rolling and performing well. There's funding available. For Tanzania, there's less funding, there's less infrastructure that supports the rollout of these systems. And therefore, even though you might have some AI tools being ready to use in Tanzania or countries like Tanzania, you're still having countries like the UK, they're much more ready to use AI than these other countries. And therefore, what you then see, I think, is the UK's diagnostic rate of diagnosing these conditions, it goes up. More people are accessing the healthcare that they need for eye conditions. Treatments improve, that kind of thing. Tanzania, even though you have some AI systems, comparatively you have a lot fewer, and therefore the rate of improvement for eye care goes up less dramatically than for these other countries that are well resourced. So how do you think we can responsibly scale AI? Like from a global perspective, do you think that the UK and countries like the UK should bear responsibility for ensuring that we're not worsening healthcare equity gaps just by jumping the ball and quickly using what we have available?
So I mean, I think, and I sort of mentioned this before, but I think part of what I sort of think my role should be, and I think other colleagues at the International Centre for Eye Health at London School would agree, is that what we try to do is support capacity for research and improving clinical care from the sort of grassroots up. I think it would be really great if more clinical researchers in Africa could be supported to do AI-based research projects moving forward. And two, I think it would be great if local African researchers could, data science researchers could develop skills in applying data science to ophthalmology and other health conditions as well. We actually have a funded project that's going on over the next 4 years where we're doing exactly that. We have a Tanzanian ophthalmologist based at the Kilimanjaro Christian Medical Center, Justus Rizwa, who is just starting a PhD with the local university in Tanzania. And part of that project is working with a Tanzanian-led data science group at another Tanzanian university. So if we can develop the kind of skills that are needed to do research and then ultimately implement technologies, AI technologies in countries like Tanzania, led by Tanzanian doctors and researchers, then I think that's the way that we can start kind of from the grassroots building this up. And if you look at most of the AI research globally, it's largely led by China and then Europe and America primarily. There's quite a lot in India as well, but I think those would be the sort of main areas. So I think if we want African and other low resource countries to actually start using these technologies, African people living in those countries need to sort of develop the skills and the understanding and the sort of momentum to actually kind of take this forward and start using it. And I think without that, I don't think it'll really happen. At scale anyway.
Sure. And I guess that's kind of a long-term project. Because that's not something that can be really easily, quickly done.
No, exactly. And I mean, I do think, the it's gonna, even though there's a lot of excitement about AI, I think it's going to take a while before it really starts to get integrated into healthcare.
Sure.
And so hopefully we can support countries like Tanzania to integrate these kind of technologies into ophthalmology services by training the local people actually working in those hospitals to do research in these technologies at this stage. And then once you've got people who've led research projects on the application of AI in their local hospitals, that's when it can then, realistically, I think, get translated into clinical services as well.
Yeah, absolutely.
Yeah.
So we've spoken a little bit about physical and financial aspects of health inequity, but I wanted to float an idea to you about the psychological barriers to health inequity. So Abbott, for our audience, Abbott recently launched a campaign called Above the Bias, wherein a diabetic patient is going about their daily commute somewhere in London. Little paper strips are being attached to his body, accompanied by comments that diabetics might receive on the daily. For example, have you checked your blood sugars, or should you really be eating that? Those kinds of things. And it ends with the man, who is now shrouded in paper strips, arriving at a clinical appointment and turning around, and the text comes up that reads 40% of diabetic patients miss out on treatment because of feelings of shame about the disease. And I guess you think psychological barriers to health equity are. I don't think it's a particular problem for maybe poorly resourced areas, but perhaps in the UK, feelings of shame prevent people from seeking the treatment that they need. So how do you think AI could be used to address this particular aspect of health inequity?
Yeah, so I mean, we discussed this briefly before, it was, you said 40% of people, which seems a relatively high percentage.
Yeah.
It wouldn't have struck me that there was a lot of shame associated with diabetes, but I may be wrong. One thing I have often thought about people living with diabetes is that their care is kind of a bit disconnected. So you end up getting hundreds of different appointments for all your different bits of diabetic care. You have your general diabetes appointment with your GP, perhaps. You have your eye screening done separately. If you've got a foot problem, you go and see the foot person differently. If you've got renal disease, you go and see the kidney physician separately. And that therefore means that you are attending hundreds of different appointments. And, you've got a life as well. You've got a job, you've got a family, you've got friends, you've got social commitments. And I can understand why, with all those different appointments, people often don't come as scheduled to their different appointments. So I think if that could all be integrated into a sort of more patient-centered single care episode where all those things got checked, I think that would, one, be a lot more cost effective, and two, be a lot better for the patient. And potentially that might be something that AI could do in the future, because you don't need necessarily a renal physician and a eye doctor and whatever else separately. That could all be done as one sort of AI device that does it all for you in one go. I think we're not there yet, but I can sort of see how patient care could potentially become a lot more streamlined in the future, and that might help with some of those issues.
Yeah, sure. And that obviously ties into the NHS 10-year plan, which has just been announced, wherein they continually push for community-based screening and much easier access to your digital health, like through the NHS app. So that's hopefully what we will be seeing, and I think AI and other biotechnology is going to be a big part of that.
Yes, I think so, yeah. And prevention is better than cure.
Prevention is better than cure, absolutely. Awesome. So just to wrap up, what are you currently working on? What's your current research?
Kind of the main things are sort of what we've discussed, really. So trying to transition, or in the process of transitioning, our research focused project on implementing an AI device into the screening program in Tanzania, and then with the Ministry of Health rolling that out into clinical practice. And then we're beginning to look at using AI to diagnose different systemic diseases from retinal imaging as well. And that sort of links to what we were just discussing in terms of sort of consolidating processes of care for people with diabetes. So potentially in the future, maybe when you attend your diabetic eye screening, you also get checked for other complications of diabetes, renal disease, risk of cardiovascular disease and stroke, etc. So we're looking at building a cohort of patients in Tanzania with retinal imaging collected over several years, and then also looking at some of those systemic disease outcomes and AI predictions of those.
But it is perhaps the most exciting application of AI. I'm pretty sure our listeners are sick of hearing this, but the eye really is a window to the body.
Yeah.
And you can see all sorts of diseases. You can predict your risk of stroke, of Parkinson's, perhaps even more. We don't know.
Well, yes, there's a lot. And, you know, that's really exciting, because then, as I say, that's a way that you can, through a retinal image, which is non-invasive, relatively easy to get, you can potentially stratify risk of all sorts of diseases, not just eye diseases, but systemic diseases, as you've said. And again, I think in a country like Tanzania, where, just like with diabetic eye disease, people often don't know they have hypertension, they don't know they have really bad renal disease until it's too late. If you could have simple automated technologies that provide access to diagnostics and pick up those diseases at a much earlier stage, I do think there's a big role for those sorts of technologies to really improve health outcomes in lower resource parts of the world.
And it would also lower the psychological barrier to treatment, particularly in the case of diabetic and diabetic retinopathy. If you go to your eye screening and they say, you have an elevated risk of hypertension, or we're starting to see early onset kidney disease, then it's kind of all in one place, diagnostic screening, which would be fantastic and takes less time out of people's days, that kind of thing. It could be really fantastic, I think.
Yes, I agree.
Awesome. So I think that concludes our little conversation nicely.
Good.
Thank you so much for joining.
Yeah, you're welcome. Thanks for having me.